Good evening. This evening we're going to have a presentation by Mr. Tart around public health and the requirements for accreditation. And so it's his show this evening. And Mr. Tart, if you want to go ahead and take over, go ahead.
Thank you. In light of accreditation coming in October, we felt it necessary to talk a little bit for about 15 minutes about what that process is, what it has entailed over the past few years, where we were 4 years ago, and some of the opportunities that the state has provided us for the accreditation process. So in 2002, the Division of Public Health and the Association of Local Health Directors undertook a pretty massive initiative, which was to develop a system of accreditation for public health departments, much like accreditation for other healthcare entities. We have fire departments that have gone through accreditation, police departments that have gone through accreditation. And we looked at doing that across the state of North Carolina. So since 2002, that has transitioned over to the North Carolina Institute for Public Health, and they have really been the support staff agency for accreditation in North Carolina. So what is the focus of accreditation? We found this to be ours, as well as what the state's capacity was, is that we want to perform at a prescribed basic level of quality. And there are three core functions that we look at. That's assessment, assurance, and policy development, and how well we do that. There are two others that come into place too, and that's governance and facilities. Governance being this board, the relationship with this board, and also the facilities that we currently occupy, how well they're ADA compliant, and some other features that the accreditation requires us to have. Within that, there are 10 essential public health services that we talked about before. Those are taken into consideration as well when we look at these performance standards. The program also focuses on a minimum set of standards that must be provided to ensure the health of the public. For instance, are we providing the right communicable disease care? Are we providing the right immunization care? Are we providing the health promotion activities that we need to provide? Now, I will say that accreditation doesn't limit the services or activities that you can provide. It just makes sure that you're providing them at that minimum basic level. Also, the accreditation doesn't create a whole new public health structure, but what it does is it links our basic standards to what we are performing. So are we performing at the level that we are supposed to be performing? Now, this is our second time through. We were accredited in 2010, and we'll mention that, but we're going through, this is our reaccreditation process, and we'll talk about the differences in just a few minutes. So what is the legislation that drives this? Well, Senate Bill 804 was signed in the fall of 2005, and that particular statute created funding for local health department accreditation. They called this an act to improve the public health infrastructure. And what they wanted to do, and the legislature said they wanted to establish that accreditation system for local health departments. And that came from a public health task force study that was done back in 2004. Now, the Public Health Task Force puts out a lot of studies based around public health specific activities in North Carolina. This was one of those activities. This legislation, as it said, also outlined the membership of the governing board and who was going to oversee accreditation in North Carolina. Within that statute as well, they do rules. And within those rules, the Commission of Health Services is required, as required by the accreditation legislation, met in 2006 to adopt and amend rules that were in place. So they passed the legislation, and then they came back to look at a standardized set of rules. They approved the rules, and they forwarded these rules to the Rules Commission for consideration. And they met in September of 2006, and they adopted what we now have as permanent accreditation rules. Now, these rules are always in a state, I wouldn't say always, but they have somewhat changed a little bit this year. But under the current situation, we feel that we're going to operate under the accreditation rules that we were under before August of this year. But they go back and they'll look at these rules to determine, do they match up with current statutes, current trends in North Carolina and around the country, and are we meeting those? And as I was saying, these rules were incorporated into the Health Department's self-assessment instrument. They have changed a little bit. Within the statutes in 138-34-1, it says all health departments in North Carolina shall obtain and maintain accreditation in accordance with 138, which are the public health statutes, and you have a copy of those. 34-4 talks that the legislation passed, they wanted to strengthen local public health. And they said in order for a local health department to be eligible to receive state and federal funding, they must be accredited. And they must be accredited by July 1st of 2014. So not only do you have to be accredited, but you have to maintain your accreditation stature. And obviously I put in there, local health department shall obtain and maintain accreditation pursuant to that. What does that mean for us? What that means is on our state fiscal year for 15, we were anticipating the reception of about $1.3 million in state and federal allocations. Now, we're not pulling in federal money directly. Most of this federal money is coming through state programs, but we consider that state and federal program, state and federal dollars. But $1.33 million. Adjudications. Within accreditation, there is the adjudication process by which the accreditation board that is set hears any appeals that we might have should we not be accredited or should we disagree with some of their accreditation findings. I think last time we had an accreditation finding that we did not agree with. We paid a visit in December when we were awarded accreditation, and we chose not to argue that point, but were given the opportunity to do so should we find evidence that we feel we were dinged, for the lack of a better word, for our efforts. That board is actually appointed by the Secretary of the Health and Human Services, Secretary that's sitting at any point in time if they change. And I will say the accreditation administrator for the entire program sits within the Institute of Public Health, and that's staffed at Chapel Hill. Just to briefly cover the titles, maybe not so much the name, but the disciplines that are on accreditation board. You have county commissioners, which sit on that accreditation board. Lee Kyle Allen, which is all the way in Craven County, all the way from Noah Woods in Robinson County. There are members from the North Carolina Association of Boards of Health. There are local health directors who are on that board. There are individuals from the Division of Public Health in Raleigh that sit on that adjudication board. And there are 3 at-large members that currently reside. Connie is a former consultant with the Division of Public Health, as well as Chapel Hill represented. So it's a wide variety of people that sit on that board, folks that will touch public health in one way or the other. There is a tiered approach, and thank Jackie for being here. She is our accreditation coordinator within the agency, and she has exhaustively looked at these 41 benchmark and 148 activities. Within our approach, we have to submit an agency self-assessment that has evidence that we have met 41 benchmarks and 148 activities within those benchmarks. There's a 3-day site visit that's scheduled by a team that comes into the agency, reviews our documentation, does the interview process. They'll look through the evidence. Hopefully they're out in 2. Sometimes it takes 3. We're anticipating 3. We try to send them our materials ahead of time so they have those electronically, so they have an opportunity to review before they get there. At that point, they will determine the accreditation status and submit that to the board for final approval. So once the team leaves, we should have some indication of where we stand at that point. This is just a snapshot of the HDS SAI. How many pages would you say? 260 pages in the HDS SAI, and a lot of the activities that we do are shown as evidence. The activities themselves are part of the evidence. The evidence doesn't necessarily drive the activities. So we want our public health duty to be reflective in the self-assessment instrument. This just gives you, I know you can't read this, but this is just a snapshot of one of the benchmarks. The particular benchmark might say the local health department shall conduct and disseminate regular community health assessments. Within that benchmark, you would have numerous activities. It might talk about, did you disseminate the community health assessment? Did you identify a couple of items with the community health assessments? For instance, we did diabetes and obesity. How are we progressing on that? All the way up to the governance, how the board operates facilities. Each one of these will have, as well with accreditation, will have a documentation to support it. Each activity within the health department self-assessment instrument is either marked as met or not met. There is no gray area. You either met it or you did not meet it. Within these evaluation component, the agency core functions and essential services, we have an assessment. There are the five pieces we talked about. On the assessment, we have to meet 26 of the 29 activities. Policy development, we have to meet 23 of the 26. Assurance that we provide the service, 34 of 38. We have to meet 24 of the 27 activities under facilities and administrative services. And Board of Health and Governance, we have to meet 25 of the 28. That's our minimum miss standard on these. We don't aim to miss any, but understanding that any particular activity, you could miss an entire benchmark. Now, when I'm not mistaken, an activity still gets you out of a benchmark.
If you miss a single activity within the benchmark, you miss the entire benchmark.
You miss the entire benchmark, so that has to be complete. The site visit team is going to be composed of not fewer than 4 individuals, and they're going to have expertise in public health. You're going to have a board commissioner or a Board of Health member. You're going to have someone with expertise in environmental health. You're going to have someone with administrative background that are in the agency to look at this particular evidence. And as I said before, they're here for 2 to 3 days for the visit. So just so you know, the Union County visit this year, we were accredited 2010. And this is my take on it. You might have a different take. I took the first accreditation visit sort of as the procedures and policies. Do you have the processes to operate in place? That's very simplistic, but that's sort of where I am. The reaccreditation site visit is, for me, did or are we following these procedures and policies, and do we have evidence to support that? For instance, if we said that we have a system for logging environmental health complaints, it's nice to have a policy. Now I have to come back and for each year they've been gone, show from start to finish complaint resolution when it comes to an environmental health situation. I would have to make sure that staff received ongoing training in current public health law. I can't just have a policy for it. I have to demonstrate it on an annual basis that they did that. So they're looking for supportive evidence now that they're coming back. That's my take on the difference between accreditation and reaccreditation. There is an interview process that's part of this. Each one that's interviewed would have that on your schedule, but there is an interview process that they will do. And they'll ask specific questions. I mean, they I don't really know what they'll ask. I'm not sitting in there, but they ask questions about that interview process. So they'll have breakout sessions while someone's looking at evidence. They'll be doing interviews during the accreditation. The final and exit conference, as I said before, we should have some indication of where we stand as an agency and a board when they leave that conference. They will give you an indication on your performance. And we will have final notification of our accreditation status by December of this year. So they'll take it back in October, they'll make their recommendation to the accreditation board, and at that point we'll know whether we receive reaccreditation or not. Should we not receive accreditation, and I didn't put this in writing, so it won't happen, is we have a set period of time to correct some of the missed benchmarks. But you can't correct these in 6 weeks, 6 months. This is a 2-year process to get these because you have to show progression over time. But we're not really worried about that, but we will know our accreditation status in December. That's just a brief overview of the accreditation materials that we have to do. They'll be here in October. We've submitted our self-assessment instrument. We did that, is it July?
June 1st.
June 1st. That's gone. We've got until June 1st to last month to finalize any things that we thought we might want to clean up, but we had to submit our evidence prior to say we are ready for you to come. And they will be here in October.
We have two commissioners who are to be interviewed. I think it's Commissioner Thomas and Commissioner Nicholas.
Yes, ma'am. Yes. That's right. And that should be set on that schedule. Any comments or questions about that? Okay. And should you have any questions about the accreditation process prior to, feel free. We'd be glad to help you with that. On your agenda tonight for the commissioners' meeting, you have a $89,000 approval process to proceed with a contract for an electronic medical records, electronic health record system. What I wanted to do tonight as the board is briefly talk to you about the system, what we need it to do, why are we moving in this direction, and what we currently have. For those of you, I'm sure you've all heard of electronic medical records, electronic health records. We use those interchangeably. It really doesn't matter, but they're all an electronic system that catalogs patient information. But electronic medical record, electronic health record, it makes no difference. Medicare and Medicaid have incentive programs that accompany these electronic medical records. So what are electronic health records? These electronic health records allow providers to capture patient demographic information. It also allows us to share that information between electronic systems. Now, the system we have, we've asked for interfaces. Those get very expensive, so you know. So sharing data is a tricky and expensive ordeal, but that's what EHRs were intended to do. And what it does is it allows that data to be shared, retrieved, transferred, where we can provide better care. That's the ultimate end game. Medicaid, along with Medicare, has an incentive program for electronic health records. What this does is this allows a federal reimbursement of a certain dollar amount back to us for a specific provider type so we can install and implement an EHR. But it's an incentive program. There are eligible professionals, and we'll get on the next slide, eligible professionals who take part in the program. And based on the numbers that we found and included in our CIP, that comes out to a maximum of about $63,000, $64,000 over a 5-year period, 6-year period for participation. Currently, our last numbers, we had 7 eligible providers in the health department. Now, if our calculations are close, now we are in 2014, the original numbers were for 2012, our reimbursement should capture dollars that would offset the cost of an EHR. So, what providers am I talking about? Specifically, the eligible providers we're talking about are physicians, nurse practitioners, the midwifery skills, the dentists, and physician's assistant who are in an FQHC. Now, we have a physician's assistant on site, but she's not eligible under that licensure as a reimbursement EHR incentive. So what are the qualifications? In order to qualify as a Medicaid EHR incentive receiver, we have to have at least a minimum of 30% Medicaid. Now, we ran some numbers today. Currently, if we pull these per provider, we're running about 40.5% Medicaid eligibility. So we do qualify. We qualified back in 2012, and we still qualify today. Anything less than this, you do not qualify. Now, the others are for rural health clinics, FQHCs, and if you're a standalone pediatrician. So what requirements do you have to meet to receive the incentive payment? To receive this payment under the Medicaid incentive program, you've got to meet certain criteria. Those we call meaningful use. For the meaningful use criteria, there are 3 stages that's part of. It's on the next slide. But in the first year of participation, providers can adopt, implement, upgrade to, or demonstrate meaningful use certified EHR technology. So in order to get the payment, we have to buy or have a system that is meaningful use compliant, meaning it meets certain federal guidance. In the second year of participation and all the years following that, providers have to show that they're using a certified EHR system. And I had a link in here I wanted you to see, but it wouldn't upload. But if you go to CMS's website, they actually have some really good detailed information on meaningful use. So there are certain stages for meaningful use that we have to meet. There are 3 stages actually. The first stage in 2011-2012, the data system itself had to be able to capture data and share data. That's stage 1. So if you bought a system that was stage 1 meaningful use compliant, at a minimum it had to capture data and be able to share data. 2014, stage 2 came into play. Stage 2 actually means that we had to see some advanced clinical processes. In other words, it had to capture information and be able to spit out certain diagnoses. And then in 2016, the federal government is requiring that we have improved outcomes, and we can show and demonstrate that people's health has changed based on the EMR technology. Here's just a few examples that we included for stage 1, stage 2, and stage 3. For instance, stage 1, you might have to use information to track key clinical conditions. In other words, it needs to be able to put in ICD codes. It needs to be able to capture information based on a diagnosis. Stage 2, we might need to be able to do an electronic transmission of this patient's data now. And to meet stage 3, the patient might need to access their own tools, their own information, their own self-management. Also, it needs to include population health. So I say all this to say the system that we're looking at needed to be compliant with these stages of federal requirement. Stage 1, stage 2, stage 3. Or at least stage 1 and 2. The current system we have in place, no stranger to that, we've talked about it many times, is our health information system. This system replaced a system that we had for about 15, 20 years prior to. Really good system it replaced. This is a state system that was implemented. Much like some other state systems, it was built as a data capturing tool. It was never built as an electronic health record practice management piece of software. This was implemented, and we've struggled ever since with this piece of technology. But right now, it does provide the state public health data for their federal funders. It's just a data capturing tool. To date, it's failed to meet meaningful use stage 2 compliance. It's stage 1 compliance, but it's not stage 2 compliance. I wanted to give you an example. This is a copy of the proposal that we put on the street. And for each one of our criteria, whether it be lab, whether it be promotion, whether it be child health, each particular system had multiple pages of the tasks we were looking for the requirement that it be met, any comments that we had, for instance, it must have the ability to build labels for lab tests, something that simple. And then we would stage it over here on our priority level. Is it a high priority, is it a low priority? If it's a low priority, it was something the group could live without. If it was a high priority, it was a must-have, and vice versa in between. But this was a multiple-page situation that we put through, and it was rigorous. But I think we had some very good requirements that closely mimic what our clinic was and what our clinic needs to be or can be. We identified a system, and that's what's on your Board of County Commissioners agenda at your Board of County Commissioners meeting, which includes, I say purchase loosely, but it includes the purchase of a new EHR practice management system that the group chose to go with. We met with 3 vendors. I think we had 6 submissions. We met with 3 that met requirements. Through these EHR systems, we picked a vendor at late July. The particular system we're talking about is an off-site hosted system. I didn't think that we had the capacity or the capabilities or the finances to host on-site with servers. And frankly, it served our needs much better. Currently, it's under legal review in Jeff's shop. I know she's looking at that right now just for some of the contractual obligations. But we selected that vendor. That's on your agenda tonight. And hopefully this system, with little to no disruption of clinic flow, we should be able to have it start to finish from the vendor and based on experiences from some other folks that have used them, 3, 4, up to 8 weeks, and we should be pretty decent. One of our criteria we were really looking at was the training schedule. I've talked to some colleagues that have used this vendor, and they said they had a very robust training schedule, something that was missing from our last upgrade, where we had individuals on site training master users with little workarounds, but an actual system that would work. And they're stage 2. I think they might be stage 3 compliant at this point. I need to go back and look, but if I'm not mistaken, they had already met all their meaningful use criteria.
And you had a list of how many different elements during, it was over 100, wasn't it? It was
Oh, it was probably 1,000.
Yeah.
We probably had close to 1,000 requirements that we had to have. Every individual section had specific requirements that we exhausted, all the way from label printing to the ability for this system to communicate with our current HIS system, because the state requires us to data dump into their system. So this system has to be able to compile our data and batch it, submit it to HIS, and set it up for us. It also has the capability of batching our billing as well, so we don't have to bill these individual insurers. It'll batch that, send it to them. They'll talk the language between these interfaces to these various insurers. We don't have to build those interfaces, and they do that. So I think all in all, for the system we received, based on the pricing we had, based on the requirements, not only pricing but specs, I think it's going to be a pretty good system should we move forward.
And isn't there a disincentive if we don't meet the deadline?
There is. Right now, there's a Medicare disincentive of 1% on the payments each and every year, and they did not provide a ceiling on that or a floor on that. Medicaid right now is exploring a disincentive program or a reduction program. I see that coming pretty quickly.
I know Commissioner Simpson and Commissioner Thomas will remember when the hospital came to us a couple of years ago because they're having to go through the same process.
It is. We also have an opportunity to work with Laserfish, who the county contracted with. That was one of our requirements in here, is that it upload into Laserfish and be able to transfer over to our electronic data storage. Right now we're storing files, static files, on CDs. Now that we have Laserfish, that's part of the requirement. So we just exhausted everything we could possibly think of under the sun for these requirements.
And that storage, about 2 years ago, that was implemented. As long as you serve me correct on
The
that.
Laserfish?
Yeah, it was associated with NCFAS, so yeah, it was about that time.
Yeah, it went in. We were using a second company, and I think it's taken time at social services to get that done, but now we're sort of back on track to get that taken care of.
Just for my own clarification,
Yes, sir.
the maintenance fees, I assume that includes the hosting fees, the whole 9 yards?
It does. That is a monthly, there's a one-time fee for the cost of the service, cost of the system. The $900 is the hosting fee, the monthly hosting fee, and any standard upgrades that came. If I'm not mistaken, that's how we read that. We met with the vendor, but that's what it was supposed to be.
And do we have you have all the hardware you need, or is that?
No, we don't. Thank you for bringing that up. That's on my slide I didn't put on here. Hardware has yet to be determined. We're exploring whether we want to do static hardware in the clinic room or whether we want to have some periphery walk-around type tablet for the provider. It just depends on our current space. I don't think in our current space the desktop units in the facility will work. When we move, it probably will, but I don't think it's going to work. We're exploring that as well. We've done some cost estimates on that. We had ranged it somewhere around in the $15,000 range, and I think our original CIP projection was $175 for the entire shebang, so we're now at $89,000 plus whatever for hardware.
Yeah, we're well within the budget.
And we want to keep it as low as we can. I know 175 was, we felt at the time, was very optimistic. Time has passed. The technology, there's a lot of competition. A lot of competition, but it's a great product. I will say that based on our experience and others' experiences, that these systems aren't necessarily in perpetuity. 5, 6 years down the road, they just don't last. But from this perspective, we think we have a system that can last at least for the next 5 to 6 years, hopefully longer.
And that $900 is through the entire.
That's
Life
for the
of
entire
having
the entire life of the process, and that's for doing all of that off-site hosting.
Thank you.
Thank you. All right, the last thing I have on the list, and if you have in front of you, there are lab fees, and I had one correction to these lab fees that. I'll throw it out there. This was the inorganic test kit was labeled at 55. I think on your list it was actually 60, and that was a typo error on my part. David Womack is here. David is our unit director in the Wells program. Just very quickly, we have fees for each one of these particular parameters currently. And if you notice, just like a septic permit, when someone gets a well permit, it's $480. That $480 includes the entire inspection plus the bacteriological sampling of that well. These particular parameters are if an individual wants secondary testing on a well. The reason we're looking at these fee increases, the state lab, in order to meet budget, has changed their costs to us for test kits, which includes the test kit and the testing. So for instance, this petroleum sample, was it $45 that went up for petroleum?
From 28 to 74.
Yeah, so from $28 testing supplies that we would buy, now they're $70 testing supplies. Same thing with nitrates, inorganic. Pesticides went up $50, so the pesticide bottle went from its current price with an additional $50 on it. What we have are two things to bring to you. These were our current rates that we felt at the time somewhat closely resembled our ability in personnel and staff time to take that sample, bring that sample back, have the lab test it. This is only a reflection of that change in the price that the state lab is passing on to us. Should we not do that, like an inorganic sampling now, say it's $57, that would be a $3 margin for us to collect it and send it off with staff time. So those are only reflective of the difference in prices that the state lab has passed to us. I know I've said that a couple times, but this is nothing additional as far as staff time allocation, calculations. It's just a straight out passing. These two, David, on the iron and the sulfur, we weren't collecting those individually.
Well, it used to be together.
Used to be one test,
And
yes,
now they're charging for them separately.
for individuals. So the state lab's charging us individually based on the cost of the individual test. And then our staff time and markup is included in those samples.
And are these only done at the time that the well is drilled, or is this something that is
This
incurred on an annual basis, or?
No, the well permit that's done on an annual, on a drill.
Right.
The rest of them are just on a request,
As needed, okay.
as needed.
Philip, give me an example of why I'd take an iron bacteria test.
David, why do you have people take iron bacteria?
Very often that's associated with a sulfur smell, like a rotten egg smell is the description of it. Or you can also actually get some slime and build up in the pipes, back the toilet bowl, where water sits for a while, you can get a reddish slime involved with that. It's not necessarily a hazardous bacteria, but it's a nuisance. It can also result in clogging. That slime can actually build up and close down wells. It can I've never seen that happen, but in other areas of the state it can.
So help me, is that, I come to the health department with that concern. I have no idea about iron bacteria, so I have this concern, and you folks suggest
Yes, sir.
that they do an iron bacteria sample.
Yes, sir.
I see.
I would say most of the, and David correct me, but I think sulfur becomes that's what most people associate with, and they were together at the time. Now they're not. We don't have that many coming in for an iron bacteria test, but you have some.
We do. I mean, it's nothing in comparison to the bacteria or the inorganic, but I don't know, 10, 15 per year. I get a lot more complaints about the odor than people that actually act on the advice we give them. But,
Rusty water. But that is just passed on. But this is it's an as needed.
As an example, though, of the price difference, the bottle that we used was $3.13. It's now $60. And that happened September 1st.
And do you in turn provide remedial information or education?
We do. The state likes us to limit that, but, I'm the one they call. So yes.
So if
I have handouts I give them. Of course, I tell them a lot anyway, but there's a lot of information on the web too. So
What we've tended not to do since we got into well permitting, water sampling, particularly for bacteria, we know what it'll do to you. The state has discouraged us from doing nothing more than giving your well sampling. Because on your individual basis, it might or might not affect you the same way it affects someone else. pH is a prime example. pH in some soft drinks is probably greater than some of the pHs in water that we're discouraging. So it just depends on you. So we don't give medical advice, but we do give pertinent information about what you're drinking. And we always request that if this sampling is falling out of the parameters, that be taken to your individual physician. Now, but if we get in there and you've got pesticide petroleum, you've got a whole different situation. We shouldn't be detecting pesticides and petroleum in your water. But as far as some of the tests, particularly the bacterials, the well testing sample, we try not to do much of that. Although David does, and I'm not saying we don't, but there's certain parameters pH just comes to mind.
So if I want an inorganic test done, it's gonna cost me $175 versus $65 now.
Now, if you want an inorganic test done,
I'm gonna buy the test kit, and then I assume the water sample's part of that?
here, let me talk to you about the test kit. Thank you for bringing that up. This particular test kit, we charge $5 for. I completely missed this. We charge $5 for you to come in and pick up a test kit and take it home and do your sampling. Send it off. That test kit now costs us an additional $55. This particular test kit, we're going to give it to you, and you can take it home, but it's going to cost you $60 to do it, because that's what it costs us to get the kit. Now, David and I talked a little bit about do we actually want take-home kits? Because someone goes home, they don't sample correctly, they get their fingers in it, it's a bad sample, they come back and say, hey, I spent $60 with you. That was different when it was $5. They could absorb that. Now it's $60. Do we want to allow them to come back, and do I sell them another inorganic test kit for another $60? Do we just do away with that and just do our own sampling and do no take-home tests? But to answer your question, if you do an integrated water sample, it was $60, now it'd be $115 if the fees pass. If it was this, we'd like it to be here.
One quick question, well permitting, does that include any of those samples, or is that strictly to come out and test whatever you test for the 480?
No, it includes several samples. David, how many total are
It's
there?
actually required, that's the only testing that the state requires is on a new drilled well. It's bacteria, the inorganic, and nitrite.
So, am I reading this correctly, our fees are going up and we're not going to increase the well permitting fee?
That kit did not go up. That comes, as we do
That
now,
comes
that
as
comes
a
in
new
a pound.
kit.
So that's not on here?
It did not go up.
It didn't go up.
Okay.
That, for comparison's sake, I was just going to show that a well permit 480, that includes all of the testing kit, and it didn't increase.
It went up in nickel. I think is what it was.
So how many man-hours are involved in doing an inorganic water sample or an inorganic test kit?
If you're testing in the home and you're going to the particular residence,
I mean, it's gonna vary, obviously, where you are in the county.
Well, once you get there, it's gonna take 10 minutes or it's gonna take 3 hours?
About 10 minutes, yeah, that's about right.
10 minutes. It's drive time. We estimated at one point anywhere from 15 minutes to 45 minutes, depending on the conversation that takes place in the sampling.
And then after that, there's the conversations about the water questions that I get. And those can last quite a while. Not always, but.
You may be the only person they see all day, Mr. Womack.
Boy, it's sunshine.
That's true.
Need a motion?
Yeah.
I make a motion, we adopt the proposed fees as presented by Mr. Tart.
All in favor? Aye. Opposed? None. Thank you, sir.
Thank you. Thank you.
I just have one thing to add on. As Frank and Cindy know, is that Secretary Walsh did come over a couple weeks ago to our site. She was so appreciative of everything that our department has done in the past year to correct problems that were there. And I would be remiss if I didn't mention that today. It was a great opportunity. She spent about an hour and a half with us and took her time, answered questions. So we were very pleased with that. During a conversation afterwards, she asked me if I would reach out to one of the other counties who's emerging at this point, which is Guilford County, and asked me to talk with them. And also, in a subsequent conversation with the Deputy Secretary, they've asked me to I'm going to Raleigh in a couple of weeks, and we're going to start talking about starting to gather as a group, since there's going to be like almost 30 or so counties that are going this way with the consolidated board, and start to have regular meetings, hopefully, to talk about, that basically to share our experiences and, what we can do better and what we have done in the past. So they're starting to get this as a statewide initiative instead of just, they've realized that since more and more counties are going toward the unified approach, I just want to let you know that we'll work with them as we go through this process to make sure that, we are collaborators with the state as we have been throughout the past year especially. So I just wanted to present that to you as well.
Great.
That's all I have.
All right. Any other questions, comments? Thank you. I'll move that we adjourn. All in favor? Opposed? None. Turn around.